So thank you very much, everyone, for coming today. We've got Stephanie Dean with F1's based at Wythenshawe, who's going to take us through the cardiovascular history in preparation for our finals. So I'll just leave that up to you, Steph. Thank you.
Great. Hi, so I'm Steph. Today we're just going to go through the cardiovascular history. It's not a obviously very comprehensive presentation in terms of all the presenting complaints, but it's to try and guide you and remind you what you need to mention in your OSCEs and what the main aim is when you're in the OSCE. So the structured approach of the history, but to remind you in an OSCE, the key things that are going to score you some points before you start delving into the history are to always make sure you wash your hands. It might seem silly for a history, but you never know what's going to score you a point on that mark sheet, and there's always some hand gel there. So always make sure you know, as you sit down, just gel your hands. Introduce yourself, say who you are, what grade you are, and that will be mentioned in the brief before you go into the room. Get their name and their date of birth, so you confirm who the patient is, and then try and get their consent as well. And it might seem a bit strange getting consent for a history because people will be used to getting consent for an examination or a procedure, but it is important in the history as well. And make sure, so you say you're here to explore the symptoms they've come in with today. So you'll be asking around that, and then you'll also be asking a little bit more about their past medical history and, about their social history and family history, and ask whether that's okay. So those are the main things to start off with, and then we'll go into the actual history. So you all know this very thoroughly by now, but I just thought we'd go over it and particularly concentrate on the cardiovascular side of things. So you need to ask the presenting complaint. So for this, you want to make sure you're demonstrating that you can ask open questions. So ask things like, why have they come in today? And what's bothering them. You don't want to start by asking closed questions so early on. So what I'd advise is let the patient talk for about 45 seconds, probably in an OSCE. And you don't want them to talk much longer than that at the beginning, because then otherwise you won't really get through it all. And the main presenting complaints for a cardiovascular history are going to be your chest pain, your shortness of breath, syncope, and palpitations. And I've got slides on those later that will go through what you need to make sure you're asking in each of them. Then we obviously move on to the history of presenting complaint. And in cardiovascular history, a really good way of going through that to make sure you're asking the right questions is Socrates, which I know you all know. So obviously it's site, onset, character, radiation, associated symptoms, timing, exacerbating and relieving factors, and severity. And you might think that it's just good for chest pain, Socrates, but as I'll go into a bit more detail later, it's actually good at triggering certain questions for other presenting complaints. So, for shortness of breath, you're not going to ask the site of the shortness of breath, obviously, but you can ask, the onset. So when did this start? What were you doing? Was it sudden? Was it gradual? So it's a really useful acronym, not just for chest pain. Systems review is next. So you want to ask your different systems. So you've got your cardiovascular, your respiratory, your MSK, GU, GI, and neuro, and systemic, as well. In the cardiovascular systems review, you need to make sure that you're asking about, and you would have done a lot of this in the history of presenting complaint, but you need to make sure you're asking about chest pain, angina symptoms, shortness of breath, palpitations, pre-syncope, syncope, peripheral edema, and palpitations. Okay. So once you've done all of that, you then need to show that you've got really good communication skills, and this is where you'll get points for asking the ICE questions, as they call it in OSCE. So you need to ask ideas, concerns, and expectations. So ideas, you can ask, you could say, thank you for telling me all that. what are you thinking is going on at the moment? What are you concerned about? And I've put the expectations in a bracket because I always used to ask the expectations at the end, but actually I think it's really good to put it in here, because you ask them what they're expecting of the consultation, and you can make sure you tick those off as you go in the rest of the history, to make sure you're getting any extra points there. And then what I would do at that point, after you've asked them, is summarize so far. So thank them for telling you all this information, and say, if it's okay by you, I'm just going to relay what you've just said to me, and please feel free to stop me at any point if you think I've got something wrong or you'd like to add anything. And it's really useful because then you know what you've missed, and you're also formulating your differentials in your head at that point, so you can ask any extra questions. And then in OSCE, it's really important to signpost as well. So you've actually already done this by asking the consent at the beginning, by saying you're going to ask about their, their symptoms at this moment in time. But now you've asked that, you can say, I'm now going to move on to asking you a bit more about your past medical history, and then we'll go on to talk about what medication you're taking, your family history, and your social history. And they always like, the examiners always like that in an OSCE. So make sure you're doing that. Past medical history, in terms of cardiovascular, it's really important to ask all these things here. So about, your hypertension, your high cholesterol, diabetes, angina. And then I've put the end there, thyrotoxicosis, because this can cause you to have palpitations. And then make sure in this section you ask about allergies, and if they do have an allergy, what will impress the examiner is not only you've asked that, but you've also then asked about what type of reaction they have if they have an allergic reaction to the substance. And then we go into the drug history. Now, when you're a doctor, you're going to obviously want to know a bit more about drug history, about the frequency and the dose they're taking. In an OSCE, in all honesty, you're not going to have time at all to ask that. So I just ask what main drugs they're taking at the moment, and it's actually really useful if they don't know the past medical history, because you can get an idea of what conditions they might have. So for example, if they've got high blood pressure, they might be taking beta blockers, ACE inhibitors, ARBs, calcium channel blockers. Heart failure, they might be on some diuretics or things like that. So you can piece the story together. Family history is then next. So you want to ask, are there any heart conditions in the family? What's significant in terms of, for example, if someone has an MI, you want to ask about what age they had this, because I think is it under 55 for a male and under 60 for a female is significant. So you want to ask that, and you also want to ask about any sudden cardiac death, or just ask about any sudden deaths, and then you can delve into if it's cardiac in nature. And then once we've, sorry, my computer's just gone. And then we want to go on to the social history. So the social history is actually really important in a cardiovascular history. So smoking obviously is very important because it's such a high risk factor for cardiovascular disease. So you need to get a thorough history of that, how much are they smoking, and how long have they smoked that for, so get their pack years. And then you also want to ask alcohol history, because alcohol, can trigger things like AF, so you might get palpitations for that. You want to ask about their diet if you've got time, because obviously, high fat foods can put you at an increased risk. And then one to ask actually is any illicit drugs here, because people taking illicit drugs can mimic some cardiac symptoms. So cocaine, ecstasy, amphetamines can cause like vasospasm of the coronary arteries and cause chest pain. So you'll impress the examiners if you're asking them that. And then you've done everything finally. So you want to close the consultation by just asking, have they got any questions or particular concerns they'd like to raise now? So that's the whole cardiovascular history. We're going to go into the presenting complaints later, but does anyone have any questions about that so far? Just put it in the chat, or you can just unmute if you want. No? Okay, we'll just put it in the chat if you want, and then we can go through it later. So just thought I'd spend a bit of time on communication skills. It's really important to get these across in your OSCE. So you want to show empathy. So this can be done verbally or non-verbally. So how you do it non-verbally, you know, if someone's starting to tear up about, you've just asked about family history and they said that, you know, their dad died of an MI, and they start to get emotional, you know, offer them a tissue, things like that. It might sound a bit extreme, but it's things like that might score you extra points. And then verbally, you know, you can say things like, oh gosh, I'm sorry to hear that. Oh, it must be tough going through this at the moment, things like that. You want to show that you're actively listening. So you'll do this naturally by responding to their, you know, what they're telling you and asking further questions. But also you can do it non-verbally as well by just having an open body language. Make sure you have good eye contact throughout. That's really important. It'll make them feel comfortable. Sorry, my Zoom's covering this, but body language, that's next. So body language is really important. At the beginning, I'd make sure you have really open body language. And then as you go through the consultation, it's really good to mimic what the patient is doing. So, you know, if they lean forward a bit, lean forward. Examiners will really like that. I've put query interruptions because obviously you don't want to interrupt the patient. You want to let them talk, but in an OSCE, I'm afraid you're going to have to. But you need to just be able to do it in a polite way. So, you know, you can stop them if it's all right by you. You mentioned something previously that I'd just like to explore a little bit further, and then you can start to ask your closed questions a bit more, because you're just not going to get time to get through everything if you've, you know, got a rambler in the OSCE. I mentioned before about signposting. Make sure you do that throughout. And then make sure you summarise as well, because then you will realise what you've not asked and what you need to ask, okay? Fine, so that's communication skills. And then presenting the history at the end of your station. So you're not going to have much time for this. And also you need to make sure it's short and snappy anyway, because you need to grab the attention of the examiner. And in real life, you'll need to grab the attention of, you know, your senior. So you need to do, your first sentence needs to include these things. So the name of the patient, the age, the background in terms of their relevant past medical history. You know, if you're talking to a cardiologist and you say straight away that they've had 2 MIs previously, it's going to grab their attention more quickly. You want to say where they are and their current condition. So are they currently stable? Once you've done that, you then need to say the presenting complaint and history presenting complaint, the positive findings of the systems review. So, and then you also want to say any relevant negative findings. So for example, if you've got someone coming in with pleuritic chest pain that you're thinking is a PE, you might want to say they didn't have a cough and they're not febrile. Just to try and show that you're excluding, you know, pneumonia as a differential there. And then say any relevant social history, drug history and family history, and then say your differential. So you say, I think this is a PE. In an OSCE, you need to read the brief, but they might also want some like initial management plan. So you could say, you know, I would also now like to conduct, you know, an examination of the cardiovascular system or respiratory system, get a set of observations, do my bedside tests such as, you know, urine dip, ECG, and then I'd like to take some bloods including full blood count, D-dimer, UNE, a chest x-ray, and then you go on to your special tests. It's very dependent on what the station is, but try and mention them if they ask you for initial investigations. Okay. So we're going to go on to the specific histories now. Does anyone have any questions of what I've said so far? It's all quite basic and I'm sure you all know it, but it was just to summarise really. Okay, so we'll go into chest pain to start with. So the main causes of chest pain, so we can split it up into cardiac, respiratory and other. So cardiac causes are aortic dissection, ACS, pericarditis and myocarditis. Respiratory are PE, pneumonia, pneumothorax, and then the other ones are gastroesophageal reflux disorder, costochondritis, cholecystitis, and musculoskeletal pain. So you've got your presenting complaint, I've come in with chest pain. And then your history presenting place, you need to, the best way to lay it out really is Socrates. So we've gone through it before, of site onset, character, radiation, associated symptoms, timing, exacerbating and relieving factors, and severity. So I've just put here in a table, it looks quite overwhelming, but it will just remind you of how to really, pin down that differential diagnosis. So we'll just go through it now. So you want to ask, where is the chest pain? Is it in the center of the chest? And then when did the chest pain start? Were you at rest? Were you, sitting watching TV, or were you on a walk, for example? And that question is really important so that you're differentiating between ACS, which obviously includes your STEMI and unstable angina, and then your stable angina. And then you want to ask, did the chest pain come on suddenly, or was it more gradual chest pain? Your sudden causes are ACS, stable angina, aortic dissection, pneumothorax, and PE. Ask what type of chest pain it is. So the different types of chest pains that you could maybe offer up to them. Did it feel like it was a crushing chest pain, heaviness, tearing, pleuritic, so pain when you breathe in, or burning. So your tearing chest pain is indicative of an aortic dissection. Pleuritic is going to be more respiratory causes, but also pericarditis. So central pleuritic chest pain is pericarditis. Not always, but most indicative of it. And then your crushing or your heaviness is going to be your ACS or your stable angina. So radiation obviously is important because in ACS you get radiation down to the arm or the jaw, not always, but you can do, and aortic dissection through to the back. And then so associated symptoms. So this is where you can really show the examiner you've literally got your differentials in your head and you're ticking them off as you go. So, ask, did you feel clammy? Did you feel anything else at the time of your chest pain? Did you feel clammy? Were you short of breath? Were you nauseous? Did you vomit at all? And then from there, they've said they're short of breath. Okay, so this could be ACS or stable angina, but then it also could be your respiratory causes. So do they feel feverish at the moment? Have they been having a productive cough? And you're just really trying to whittle down your differentials here. I'm not going to go through them all, but you can see that you can look at the table after in terms of what associated symptoms will give you your differential. You need to ask about the duration of the chest pain, and this is to try and differentiate between ACS and stable angina. So if it's lasted over 20 minutes, this is more likely going to be ACS, and if it's less than 20 minutes, stable angina. And then I always ask, does anything make it better or worse? For example, any particular position or any medication that you've taken. So you ask about position because in pericarditis, by sitting forward, it will relieve the chest pain to an extent. And also in terms of medication, so GTN should relieve stable angina, and GTN might improve ACS, but it won't resolve it at all. Okay. And then once you've done your history of presenting complaint, that's where we go back to our structure and we go through the systems review. So you might have asked a lot of this already, but you also want to make sure that you tick off that you've asked about your cardiovascular ones of orthopnea, paroxysmal nocturnal dyspnea, palpitations, and syncope. One of the main systems to get a good systems review as well in this case is a respiratory one, because you have got quite a lot of respiratory causes of chest pain. And then you go through your ICE, you summarise, and then you realise any gaps that you've got, and you can ask them any further questions to fill those in, and then signpost that you're now going to move on to the past medical history. It's important in this case to ask about any respiratory conditions that might make them susceptible to getting pneumonia, a PE, for example, and then you want to ask them about any GI conditions. So, do they suffer from reflux normally? Is this just a bad case of reflux, or do they have a peptic ulcer that might be causing this? Are they known to have gallstones, which could cause cholecystitis? So once you've asked that, you're then going to go on to your family history and drug history. And then your social history, like we've said before, really important to ask about smoking because it does increase the risk of cardiovascular disease, VTE, so obviously which is your PE, and then pneumonia as well. And then, like I said before, just ask about illicit drugs because, you can get chest pain from use of these illicit drugs. Okay, any questions about chest pain? Okay, I'm going to take that as a no. So it's really important that we get these summaries right. So I've just done an example here of a patient, and then it would be great if one of you could try and summarize this patient for me in a couple of sentences. So if you want to volunteer, that would be great. But we'll go through it first, okay? So you've got Mr. X, who's a 68-year-old male. He has come in with chest pain. You've gone through your Socrates and it's central. It came on suddenly whilst he was watching TV, so he was at rest. He felt there was a heaviness in his chest. It didn't radiate anywhere. He did feel short of breath at the time and also nauseous. It lasted, it's still going on now, and it's lasted over an hour, and GTN has not relieved it. It's got no other symptoms on systems review. He's really concerned that he's having a heart attack and that he'll die like his dad did because his father passed away at 80 from an MI. His past medical history is that he's got type 2 diabetes and stable angina. His drug history is on metformin for his diabetes, atorvastatin for primary prevention, and GTN spray. He's a non-smoker and he drinks 3 beers a week. He's got a good diet and he takes no recreational drugs. Oh, this is one thing that I forgot to say actually, sorry, before. In the social history, try and ask really quickly about their ADLs. It's more important for a geriatric patient, but just ask really quickly, can you get up, wash, get dressed, clean, and cook for yourself? and then if they can't do some of that, what's a nice little question is are the symptoms you presented with now affecting that? Is it stopping you from doing anything? Okay, does anybody want to try and have a go at summarising this patient? Anybody? Okay, don't worry. Right, so we'll just get rid of this and we'll do an example. So Mr. X is a 68-year-old male with a past medical history of a type 2 diabetes and stable angina. He's presented to ED with chest pain. So he presented with sudden onset central chest pain with associated shortness of breath and nausea. This came on at rest and his GTN spray has not relieved it. It has now lasted over an hour. No other symptoms on systems review. He has a relative family history as his father passed away from an MI in his 80s. He's currently taking metformin, atorvastatin, and GTN spray. So there you've just summarised it really nicely in a few sentences. And you would then, in an OSCE, it depends on your brief, but say, I think this is blah, 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 and, ACS. I would like to conduct a full examination and do the following investigations. I've just seen someone's asked about phrasing about exercise tolerance. So you'd basically ask, when did this, so you need to ask when the symptoms started. So say if they started 2 weeks ago, this is more for a shortness of breath question. But if the shortness of breath started 2 weeks ago, and the shortness of breath comes on more when they're exercising, or going for a walk, say, okay, so prior to 2 weeks ago, how far could you walk? Could you walk to, have you got a shop down the road, you know, that's around 200 meters? Could you walk to the shop? Could you walk to the park? And then ask now, you know, and then, so what about the situation now? Can you still walk to the shop? Can you still walk to the park? And then you can get an idea of really how much their day-to-day activities are affected, and how much their exercise has been reduced. I hope that is okay for an answer for that. Okay, so we'll go on to our next one, which is about transient loss of consciousness. So this is from the 2018 ESC guidelines. It's a really good little diagram, and it basically splits transient loss of consciousness into non-traumatic causes and due to trauma, so head trauma. And the main thing for your guys' OSCEs is going to be looking at this non-traumatic transient loss of consciousness, and you're going to be trying to differentiate. You're going to try and show in your history and differentiate between, is this a seizure that's caused a loss of consciousness, or is this syncope? And there are different causes of syncope. There's reflex syncope, which is you have a reflex, you know, drop in blood pressure and heart rate to cause you to lose consciousness, orthostatic hypertension, and cardiac causes because of a reduced cardiac output. And so if you've then differentiated that this is syncope and not a seizure, you then want to show that you're going to try and figure out what type of syncope, what type of cause this is really. So let's just go into syncope a little bit more. So cardiac causes of syncope can be a PE, aortic stenosis, arrhythmias, aortic dissection, and cardiac tamponade. And then reflex syncope is going to be your vasovagal episodes, going to be situational, and carotid sinus hypersensitivity. And carotid sinus hypersensitivity is when you know, a typical history is when someone quickly turns their neck, or they might be wearing like a really tight collar and they do this, and then they might have syncope. Orthostatic hypertension also is another cause. That's obviously when you get up, you drop your blood pressure, and you have a syncopal attack. So you've got your presenting complaint of, you know, I fainted, I lost consciousness. The history of presenting complaint, I would always, you know, model this in terms, or demonstrate that you're going to find out the cause by asking before, during, and after. So if we just go through it a little bit, the main questions you want to ask are, what were you doing just before this episode happened? So here you're asking, what triggered this? And in a seizure, now I know it's really cliche, but OSCEs are a bit cliche, and you know, they might have been, were they in a concert, where there was loads of flashing lights, because that can sometimes trigger epilepsy, okay, an epileptic seizure. For orthostatic hypertension, were they just getting out of bed? Were they getting up from a chair? Cardiac causes of AS and arrhythmias, so they might have been exercising. That can sometimes be a trigger to these syncopal episodes. A vasovagal episode might be triggered by emotional distress and prolonged standing. Situational, so they might have just been, you know, having a bit of a coughing fit, sneezing fit, or they might have been defecating or voiding. And then carotid sinus hypersensitivity, they might say, you know, oh, I just turned my head really quickly, and then I fainted. And then once you've got the triggers, you want to ask about, did they have any symptoms beforehand? So in a vasovagal episode, they might have felt lightheaded, have a bit of a visual disturbance, and might have been a bit clammy and nauseous before. Cardiac causes, they might have chest pain or palpitations. And then when you're asking about the chest pain, you need to ask whether it was this tearing chest pain, which is indicative of aortic dissection. And then in epileptic seizures, they often have these like auras of a specific smell or taste, you know, or they might see visual flashes, and they tend to describe these things. They've had them before, a bit like deja vu. Yeah, so that's the before section done. Then you want to ask what happened during it, and it's really important you ask, did anyone witness this? And if anyone did witness it, that's great. hopefully, you know, they're the relative in the room in the OSCE. So you can ask them. If not, after you've done the history, you want to say that you want to get a collateral history to try and confirm what happened. But in a seizure, obviously, they might say that they had, you know, increased tone and they were shaking, which is your tonic-clonic seizure. They might have bit their tongue and they might have been incontinent. And then you want to ask whether how long if they were unconscious and how long they were unconscious for. So reflex and cardiac causes are going to be a short duration, and when you're having a seizure, it's going to be a longer duration. And then once you've asked about what happened during it, you need to ask how long did it take for them to regain consciousness. So, you know, a shorter time is indicative of reflex and cardiac, and they will be more orientated. A longer time and confusion after the episode is more indicative of seizure. And then I like to ask, after I've done all of this, so you've done a really good history in asking the events here. What I then like to ask is just to check for any injuries. So did you hit your head whilst you know, fell to the floor? Or did you hit any other part of your body? Is there any pain at the moment? And that just shows you that you're thinking not just about what the cause is, but what the damage is after. And then once you've done that, so you've done a really good history of presenting complaint, you just need to go through the rest of the history like we've said before. Some key things to pick up on here. In the systems review, it's quite good to ask about systemic symptoms in terms of weight loss and also morning headaches for neuro, because a space occupying lesion can be a cause of a seizure. A GU and GU system review is good because if they're oligureic or have diarrhea and vomiting, they might be dehydrated, which can basically make them more susceptible to having orthostatic hypertension. And then you want to obviously ask your respiratory and your cardiovascular, like we've gone through before. In terms of your past medical history, you want to make sure you've asked about any previous episodes where they've lost consciousness. Got a diagnosis of Parkinson's or diabetic neuropathy, because you can get autonomic dysfunction with this, which can cause orthostatic hypertension. You know, have they had an MI, a pacemaker, or do they have epilepsy, which is causing the seizure? And then in this, just to point out, if you're running out of time, try and get a drug history in there, because it's really important for syncope, because rate limiting drugs, you know, like bisoprolol or even like timolol can cause syncope. So it's good to try and get what they're on. And then also like antihypertensive or diuretics can cause you know, make more susceptible to orthostatic hypotension. One thing that I think actually will impress the examiners in this is if you ask about occupation and driving, and they say, you know, they work with heavy machinery, then it will be good that you're thinking ahead, and you might have to break the news or suggest to them that whilst they're having investigations for this, it might be wise that they, you know, stop work or they stop driving, for example. Okay, I realise I've talked for. So the differential, there's many different differentials for palpitations. So your arrhythmias can cause it, so like your SVT, VT, AF, and your ectopics. And then there are other causes like anxiety, hypothyroidism. You can just get, you know, I've not put them on there, but physiological as well. And rare causes like pheochromocytoma, which can cause like sinus tachy's. The main thing that you want to ask initially when someone says they've got palpitations is, what do they mean by palpitations? Everyone can have, you know, different meanings for this, really. So you really want to delve into what they're trying to describe by a palpitation, okay? And I like to you know, structure it via Socrates, really, and this is the history presenting complaint. So you're not going to ask all of the Socrates, you're not going to ask the site or do they radiate, but you can ask the onset. So did they come on suddenly or gradually? What were they doing at the time they started? Character, you know, do they feel fast? And do they feel regular or irregular? What's quite nice is if you could ask them to tap out the beat. It might be hard if they, you know, they've only had one episode and they can't remember. But, you know, if this is someone who has them all the time, you could ask them to demonstrate what it might be like. And then you need to ask them, you know, does it feel like a missed beat? Because that can be indicative of an ectopic. You also want to ask about associated symptoms. So, you know, do they have sweaty palms when these palpitations come on? Do they have a tremor? Are they generally low in mood at the moment? So that might, you know, indicate that it's anxiety causing it. Heat intolerance, sweating, weight loss and tremor might indicate that it's hypothyroidism. And diarrhea and vomiting, they might just show that, you know, you're a bit hypovolemic and you've got electrolyte abnormalities that can be triggering these palpitations. You also want to ask in terms of timing, how long have they been experiencing these for, and how often are they having them, and how long do the palpitations actually last for? And then you want to ask about, you know, exacerbating factors, and these are your triggers. So are the palpitations triggered by exertion or anxiety? That might be your sinus tachys. Is it triggered by alcohol, caffeine or fatigue? It's really important you ask those because that can trigger your ectopics. And alcohol and exercise can also trigger AF. You can also ask them, did anything help terminate the palpitation? So, for example, people say they've, you know, held their breath and that helped stop it. That might show that it's an SVT because they're doing a bit of a Valsalva there. So I've got one of these tables again. So they always look quite overwhelming, but it just splits it up for you. So we'll go through it briefly now, if I'm okay for time. I'll go through it briefly. So your ectopics are more going to be the sudden onset palpitations. The patient might describe it as a missed beat, and they're intermittently irregular. They don't last very long typically, they're brief, but the triggering things might be, you know, they always get them after they've had a lot of caffeine. Are they tired at the moment? Alcohol. Sinus tachys can be physiological due to a pheochromocytoma or anxiety. They are regular and fast. They might have other symptoms of anxiety, like I said before, like palm sweating, tremors. And they might be in anxiety-induced situations. So, you know, if you ask, does anything make them worse? They could be, you know, if they've got a phobia, you know, is it when they're in a crowd, for example? SVT, so these are very sudden, very fast and regular. You might get some extra symptoms like they might feel lightheaded and chest tightness at the same time. These can last actually from minutes to hours. And they may be relieved by Valsalva, vagal maneuvers like Valsalva, and also the carotid sinus massage. But patients that are presenting with these for the first time might not, you know those tricks to help them. AF, are sudden, irregular and fast. You might also get shortness of breath and fatigue with them, and they can be triggered by alcohol or exercise. And then VT it comes on suddenly, it's regular and it's fast. You might get symptoms like pre-syncope and chest tightness at the same time. And then you've probably asked a lot of these in your history presenting complaint, but it's just to make sure that you ask these red flag questions of whether they had syncope at the time. You know, then you're basically combining your two histories there, really, aren't you? Pre-syncope, have they had any chest pain with it, shortness of breath or sweating? And these are important to tell you the severity of it and whether and how urgently you need to get these investigations done, really. Okay. So you've done then a really good history presenting complaint, and then you're going to ask the rest of the history. So I'm sure you're probably bored of slides like this by now, but it's just to hammer the points, really. So you do a good systems review. You would have asked most of it, and you've definitely asked most of it with your red flags as well. But make sure in cardiovascular wise you ask about orthopnea and PND. And the past medical history things that are good to ask in terms of palpitations are whether they've ever been diagnosed with an arrhythmia or a problem with their valve, and ask if they've ever had an ablation. Patients might not know what that is, but if they don't know what it is, most likely means they've probably not had one. And then you can, if you've got time, include a brief mental health history in terms of, is anxiety causing these palpitations? It's important in the family history to ask about sudden cardiac death because arrhythmias can cause this. And then in the social history, obviously you're going to ask about alcohol. And then in terms of, for chest pain, you're asking about the illicit drugs, but you also need to ask about them here because cocaine, ecstasy, amphetamines, and cannabis at a low dose actually can activate the CNS system. Not CNS, SNS system, sorry, and then cause a tachycardia where you might get palpitations. And then once again, mention about the occupation because if they're having any of the red flag symptoms like syncope, for example, they might need to take time off work and might need to stop driving. Okay, the last one is shortness of breath. So the main differentials for shortness of breath, so you've got your cardiovascular causes, which are obviously ACS, a pericardial effusion, valve disease, arrhythmia, and heart failure. Respiratory obviously is a massive component, which and a PE, COPD, asthma, pneumonia, and pneumothorax can cause shortness of breath. And other ones like anxiety, anaphylaxis, and DKA, or metabolic acidosis, which you get in a DKA, can cause shortness of breath. So how to approach the history? You can use like a Socrates type thing again, but obviously you don't need your site or your radiation. So it's kind of like the oh sorry, my computer's just shut off. So it's like the palpitations really. So my last little table. So the onset. So you want to ask, did the shortness of breath come on very suddenly? Did the breath come on suddenly, or was it more gradual? The sudden causes of shortness of breath are going to be your ACS, your PE, your COPD, and your asthma, and your pneumothorax. You also want to ask, what were they doing at the time they got short of breath? Is it on exertion mainly, or do they just have it at rest as well? I've put pleuritic in character, because I know pleuritic is like more of chest pain, but when they take then more breaths in, if they're short of breath, do they get pleuritic chest pain as well? And that's going to be more your respiratory causes of pneumonia, PE, and a pneumothorax. Once again, like the chest pain, so the associated symptoms bit is so important here that you're showing you're going through your differentials. So in heart failure, you're going to get, your breathlessness when you're lying flat. You're going to get, you might get breathlessness when you're lying flat. You might get, paroxysmal nocturnal dyspnea, which is where you wake up suddenly at night and you feel like, you're drowning, you're really breathless. And then you might have to, the classic is, you sit up at the edge of the bed, or you might need to go to the window for some air. And you might have peripheral edema, and you might have a cough, which has got a bit of pink frothy sputum. In ACS, you're going to get, we've gone through this already, but your chest pain, your nausea and sweating. Pneumonia, if they got a cough, is it productive? Do they feel feverish? And have they got any rigors? So I've explained, I'm just cautious of time, but I've explained the rest there in the table, which you can look at in your own time, but make sure you ask all about these associated symptoms. And then you want to ask about timing. So has the shortness of breath gotten gradually worse over time, or is it more sudden? So, it's just been today, for example, it suddenly came on today. And then you want to ask about exacerbating and relieving factors. It's more respiratory, but it's good to ask about, does the cold or does exercise or any allergens make it worse? Because that's indicative of COPD and asthma. Okay, so that's actually it for the for presenting complaints. To conclude, with your OSCEs, I know they can be really scary, but you just need to make sure that you're just practicing, with your house, well, if you live with medics or your friends, as much as you can. Practice trying to fit it into the time that you have, because then you'll start to gauge when you need to move on to the different sections in your history. And so in the real thing, you'll know when to politely interrupt them, or start to bring in more closed questions. Make sure you read the brief before you go into your OSCE station, because that will tell you what you exactly need to do in the station. So if it's take a history and say your most likely diagnosis, then that's all you have to do. But make sure you check, is it asking for your initial investigations? Because there will be separate components on the mark sheet that include all of those. Make sure you ask open questions at the beginning, but then don't be afraid to go into closed questions once you've done that, to try and get through the history in a succinct amount of time. Stick to the format we've gone through today, and present it succinctly. So that is everything, I think. Oh, I've just put at the end here, you guys will get all these slides. The really useful sources are obviously the OSCE Stop, Geeky Medics, and I've put the ones that I've used here in the presentation. And I actually have McLeod's clinical examination book, which is useful to read the history sections in it, and is obviously relevant to this talk, but it's also really good for your examination techniques. So yeah, I would just go on those websites if you're struggling. And I know they have little tables or like checklists, that when you're doing it, practicing with your friends, you can go through and make sure that you're ticking all the right things, really. That's it. Has anyone got any questions at all that you'd like